Good evening, guys. Please just give me a thumbs up if the audiovisual part is all okay, which means you can see me, you can hear me, and you can see my pointer here on the board. So please just let me know if the audiovisual part is all okay, so that I can just get started with the session. So is the audiovisual part all okay? So all right, perfect enough. So I think things are all going well. I'm able to see your comments and uh, perfect enough. So I think then we can just get started with this series targeting the upcoming FMG exam. But before that, quick introduction of myself, Dr. Mukul Mohindra, your orthopedic instructor here at Unacademy. Perhaps this is a session where this FMG exam is being targeted by me in such a way that I intend to discuss some topics I expect will be there in the upcoming exam. Perhaps it's a guess based upon my understanding of the exam as I watched questions coming to you over the year. Good evening, guys. Good evening, Sahil, Rishi, Mishap. So, good evening to all of you. So, what I've observed, over past few years, that somehow the foreign medical graduate exam definitely focuses a lot on asking you about accident and injuries, trauma part, fractures. Perhaps you can find at least some 6 to 10 questions from this particular area. And perhaps in this session I've kept my discussion exclusively on the fractures part, the trauma part, and I'll try touching all the important areas perhaps that have been in your exam over past 3 or 4 years, and I'll try conveying you the important information as well as the important concepts. But since we have very limited time, this is around 1.5 hour session. Without wasting much of time, let's quickly get started. Alright. Now this image has been one of the very popular images that have spanned across multiple exams including the FMG exam. You can see here that this tip of the finger is bent. So basically what has happened over here, that you have the extensor tendon going like this, and somewhere over here the extensor tendon continuity has been ruptured. So that is why perhaps this distal finger, it has dropped down. Yes, you are absolutely right, Sahil. Fairly easy one, I know. The answer here is mallet finger, because that's what you tend to have in mallet finger. Rupture of this tendon, extensor digitorum communis, and this ruptures from the base of the distal phalanx. So that's exactly what is called mallet finger. So somewhere here from the base of distal phalanx, this extensor tendon has ruptured and this finger has dropped down. So that's exactly what is mallet finger. The answer here is undoubtedly D. But I would just like you guys to know one extra point here. The counterpart of mallet finger is jersey finger, and the tendon that ruptures here is flexor digitorum profundus. So when the flexor tendon ruptures from the base of distal phalanx, that jersey finger, and when the extensor tendon ruptures, that is mallet finger. I must put it into your mind one extra point: the treatment of these injuries. It requires immobilization of the finger in this very special splint I have shown in front of you, and this particular splint you see in front of you, we popularly call this as a frog splint. So mallet and jersey fingers require treatment in this special frog splint. So please have a good look at the images also. Perfect. Alright. So I'll just move forwards to another very nice and very routinely and commonly asked question. An adolescent has come to you with that history: fall on an outstretched hand. Now for management of this injury, you tied this plaster, cast. You can very well see it in the image. Now looking at this plaster cast, you have to tell me what's the expected fracture this patient would have been suffering from. So look at the fracture. Look at the position of the hand in that plaster. And looking at it, you make a guess as to what is the expected injury. Okay, so Sahil's done his homework very nicely. You're absolutely right. Right, Sahil, the answer here is scaphoid fracture. And perhaps I don't think I need to tell you, the typical position that has been shown to you is the glass holding position. So just a little bit of information here. See, Colles and scaphoid fractures are managed by plasters that have very classical position of the hand. In Colles fracture, what you give is a hand shaking cast, but in scaphoid fracture, what you give is a glass holding cast. So you can see very well, I've shown with this very nice image how this position looks like a glass holding position. So what you have in glass holding position is dorsiflexion at the wrist plus a lateral deviation at the wrist. So that is exactly what is in glass holding position. The hand shaking cast is absolutely the opposite. Rather than dorsiflexion at the wrist, what you have is palmar flexion at the wrist, and rather than a lateral deviation at the wrist, what you tend to have is a medial deviation at the wrist. So you have palmar flexion and you have medial deviation. So that is how you shake hand. And when you reverse, dorsiflexion, lateral deviation. I'll just do it for you. So I'm holding a glass for you. So this dorsiflexion and lateral deviation, this position is what is a glass holding cast. So I think very much of a common sense scenario. I've used perhaps both the positions in front of you, and you can now very well imagine what would be a glass holding position, what would be a hand shaking position. So please do remember the two important scenarios where you give the two opposite positions for a plaster. Okay, so that's absolutely right side. This is a glass holding cast you give in scaphoid fracture. Full marks guys, full marks till here. Very nice. So you guys are pretty attentive also, and you've done your homework in a very effective way. But let me see if you guys can click here. Just a repeat question from the FMGE exam that has just gone by. A very nice question. So there is a very clear-cut deformity that's obvious here at the elbow. Now you have to tell me this particular deformity that's obvious over here would best be, alright, so Bishop says coxa valga. Okay. B, yes, cubitus valgus. See, coxa is the term that's used at the hip. So if you have varus valgus at the hip, this is elbow. The word used in elbow is cubitus, and absolutely this is cubitus valgus only. Okay. The opposite of cubitus valgus is rather cubitus varus, and cubitus varus is what you call as the gunstock deformity. Perhaps I'll just let you know that also. See, what is varus and what is valgus? If you look at this elbow, you will find distal to the elbow the limb is going laterally. L for laterally, L in valgus. So when you find distal to a joint, a limb is going laterally, that is where you use the word valgus. Now absolutely opposite happens in varus. If this is the elbow, you can see distal to the elbow, the limb is going medially. So that's why I'm calling this as varus. So in cubitus varus, the limb distal to elbow will be going medially. और याद रखने का तरीका, how to remember, is this way: L laterally, distal to elbow, L laterally, L valgus. So if the limb is going laterally, here L should mean laterally. That means this is a case of valgus. Mind you, may it be elbow, may it be knee. Like see this knee. So if you see, this is knee, but distal to the knee, the leg is going laterally. So L laterally, L should mean valgus. So this will be genu valgum because this is knee. Okay. In a similar way, if you see, this is the position of the knee, and distal to knee, if you see the legs, they are pointing medially. So since they are pointing medially, and this is knee, the word used will be genu, but then this will become a case of genu valgum. So I hope you are clear with varus valgus in a very effective way. What is varum, what is valgum, बहुत अच्छे से समझ में आ गया है. And I hope you got my message that these are common terms, varus valgus. They can be used with respect to any joint. You use them in knee, it is genu. You use them in elbow, it is cubitus. You use them at hip, it is coxa. Got the message? One small thing. I would just like to let you know the important causes behind each of these deformities in children, कि बच्चों में अगर ये डिफॉर्मिटीज मिल जाएंगी तो इनके पीछे सबसे कॉमन कॉज क्या होने वाला है. फॉर क्यूबिटस वायरस आई डोंट थिंक आई नीड टू टेल यू, you're already very much clear with the commonest cause. It's a fracture around the distal humerus, that is fracture supracondylar humerus. Okay. Cubitus valgus rather occurs in fracture of the lateral condyle of the humerus. So clear with the important causes behind these deformities here. Okay, in children. I'll also tell you the causes with genu varum and valgum to be considered if you find these deformities in children. Genu varum is generally the outcome of rickets if you talk about children, and genu valgum is generally idiopathic. No cause you will be able to identify. Many people think that this is likely from a growth plate defect. So abnormal growth in children is what leads to genu valgum. But I hope you are now clear with the causes behind these deformities also. You are crystal clear with the identification of these deformities also. You are crystal clear with the fact that gunstock deformity, what you guys popularly know as that gunstock deformity, is nothing else. It is cubitus varus. That's how the gunstock looks like. Okay, and you are familiar with the causes of these deformities also. So all comfortable till here, guys? Please just give me a thumbs up. अभी तक सब comfortable है? Is all okay? You are able to understand everything? Fair enough. Thank you, Sahil, for that thumbs up. So now a question on Bennett's fracture. So if this term Bennett's fracture is used, it would best describe which of the following scenario? Yes, Bishop, Smriti, Sahil, Abdur, anyone who wishes to answer, and no negative marking in my cards. Please feel free to answer. You commit a mistake here, you have the license. This is just a class, and a mistake here would just become a memory. So please feel free to interact with me. You can answer, at ease. I absolutely don't mind even if you give me a wrong answer. Okay, Bishop says no idea. So that means I have to tell you what is the Bennett fracture. No problem, I won't, Bishop. Not a problem, but at least thanks for letting me know. See, this would be my best pick here. Okay, and this is a very deceptive choice that traps many people, like, Sahil has been trapped over here. See, there are two fractures actually, Bishop, that you need to know in the thumb. One is Bennett's fracture, and another one is Rolando fracture. Now, both Bennett and Rolando, they are basically intra-articular fractures that involve the base of the first metacarpal. Mind you, this first metacarpal would mean the metacarpal of the thumb. So they are basically fractures involving this thumb metacarpal, and this would be the base of the thumb metacarpal. I have encircled it for you. Now if this is the metacarpal, these would be the carpals. So these are fractures of carpo-metacarpal joint. Carpo-metacarpal joint. Please, this is the metacarpal, this is the phalanx. So this is the metacarpophalangeal joint. So metacarpophalangeal joint is paired. The metacarpophalangeal joint is paired. This is not the answer. It is the carpo-metacarpal joint that is involved. So trapezius is a carpal bone. This is a metacarpal. So here what we are referring to is carpo-metacarpal joint. So that's how this is the answer. Got the message? So clear the area that will be involved with Bennett's and Rolando, and clear with your mistake. Perfect. So both of them are fractures of this area, and they are intra-articular fractures. Now of course I would take this opportunity also to tell you what is the difference then. The difference is basically the shape of the fracture. Bennett is basically an oblique pattern fracture, Rolando is more so of a Y-shaped fracture. Like if you see here this Y type of a shape, you see that Y pattern, that is Rolando. You see that oblique pattern, that is Bennett. See, the basic problem with an oblique shape, you can have displacement. An oblique thing, can very easily slip. So displacement will be very common. और कई बार एग्जामिनर पूछ भी लेता है which muscle displaces Bennett's fracture, and then this is the best answer you have to give: abductor pollicis longus. Another repeat question from the old FMG exam couple of years back. This question was there: which muscle would displace Bennett's fracture? And the answer was abductor pollicis longus. Clear with that? So I hope you're clear with that. Okay, Devanshi, I'll answer your question also. Before that, just answer a small question from my side. Actually, this image with which I explained to you Bennett's fracture is not carrying any fracture here. The fracture carried is somewhere over here. I've tick marked that area also for you. So first just identify the fracture that is actually shown in this image, and I'll go back and answer your question also, Devanshi. What is coxa vara? What is coxa valga? Not a problem. So please, can you just help me out, guys? The fracture that I've marked for you, what is exactly? Yes, absolutely right, side. You're absolutely right. What is shown is actually the boxer's fracture, and that's actually a fracture that involves the neck of the fifth metacarpal. So I'm very happy that you're able to pick up these fractures from the x-rays. Very nice, very nice. But keep doing that, because what I've observed in my experience for the past few years, plenty of x-rays in the FMG paper, plenty of x-rays. When you talk of the hip, the term coxa vara and valga is used with respect to neck shaft angle. When the neck shaft angle is higher than normal, it is coxa valga. When the neck shaft angle is lower than normal, that is coxa vara. So if this is the proximal femur, I'll draw a line along the neck, I'll draw a line along the shaft, and what would be formed here would be the neck shaft angle. So basically there is a neck shaft angle that generally averages around 125 degrees. When you find the values more than say 130, 135 degrees, you say this is valga. When you find values less than 120, you say this is vara. So Divyanshi, are you clear with your query also? Clear with your query also, I suppose. That's okay. Fine. So no harm. If you are not clear with anything, please just feel free to ask me, and I would love to answer your queries up. Okay. So all queries answered till now. Okay. Alright. Now there is a fracture that's shown over here. You have to tell me the best terminology with which I can denote this particular injury. So the fracture that is shown over here would best be labeled as, okay, Sahil says the fracture that is shown over here would best be labeled as, so there's a fracture that's shown over here. So this is not a boxer's fracture, Sahil. Mishap says Kohli's fracture. Close, but not the perfect answer here. Yes. So the fracture that you see over here, I think I'm not able to see all the, yeah. So the fracture, Sahil says Schoffer's fracture. You're absolutely right. So this is actually a Schoffer's fracture. This is also called as Hutchison's fracture. Okay. This is no way a bumper fracture. That is absolutely a different term. See, this injury, bumper fracture, was there in the FMG exam 2 years back. Bumper fracture is basically a fracture of the proximal lateral tibial plateau. Now when the question came up, the question was very simple as to how to define a bumper fracture. Now you can very well imagine that a car would come and hit you from outside. So it will be this lateral tibia that will be fracturing, not the medial. The question had this confusion: a fracture of proximal medial tibial plateau, a fracture of proximal lateral tibial plateau. And then you have to imagine that a car would hit you from outside and it will be the lateral tibia that will be usually fracturing, and that is how you have to pick up the answer here. So bumper fracture is something that goes to the proximal tibia, and this is radius that is shown, so that is totally out of the context here. So I have to concentrate on the other choices. Now Colles fracture I will again rule out because of a very important fact, that Colles fracture is an extra articular injury. The joint is not involved, and I hope you can very well see here the wrist joint getting the injury. So this is an intra-articular fracture. Clear with that? So ये joint को involve कर रहा है, तो ये intra-articular fracture है. So that means the answer has to be from Schoffer or Barton, because these are the fractures that will be involving the joint. So what is the difference between these injuries? I'll tell you. So first of all, this is Colles fracture. So you can see this is the metaphyseal fragment, this is the diaphyseal fragment. तो ये पूरा metaphyseal fragment है, ये पूरी diaphysis है. In Colles you have a metaphyseal-diaphyseal junction fracture, and there is a dorsal displacement of the distal fragment. मतलब distal fragment जो होता है that goes पीछे को dorsally. So this distal fragment has gone dorsally. Now if you see again a metaphyseal and a diaphyseal junction fracture, but if you find the distal fragment has rather gone anteriorly in front, what you are seeing is reverse of the Colles fracture, and that particular injury now gets called as Smith's fracture. So clear with that? So I think you're now pretty much clear as to what is Colles and what is Smith, and I hope you have clearly realized that both these injuries are extra articular. They are not involving the wrist joint because they are metaphyseal diaphyseal junction fractures. They are not involving the joints. Now just in case this joint gets involved, like if you see here there is a fracture going into the wrist, then the term to be used for this fracture is Barton's fracture. So in Barton's fracture you will have an intra-articular fracture involving this distal end of radius. But in Barton's fracture you always find along with this fracture a subluxation of the wrist. I hope you can see that this is a fracture going into the joint, and this complete wrist joint is subluxed anteriorly. तो wrist joint में dislocation, एक subluxation भी मिलती है. So Barton's is not just a fracture, it is a fracture dislocation. But in Schoffer, no dislocation of the wrist. So both these will be intra-articular fractures at the distal end of the radius. Here you will have a dislocation of the wrist along with that fracture. Here the wrist will not be dislocated. So even if you see this fracture, the styloid process is broken. So that is Schoffer, a fracture involving the styloid process of radius. But there is no dislocation of the wrist that is part of it. Got the message? So Mishab, Som, Sahil, Smriti, you all guys are clear with as to what happens in Colles, what happens in Smith, what happens in Schoffer, what happens in Barton's. You'll be able to pick it up from these x-rays, like as to which injury are you guys dealing. See, so easy. Perfect enough. Now there is another very clear-cut fracture shown in front of you, and you have to look at this fracture and you have to give me an idea as to like what could be the likely injury here. So you have to identify the fracture that's shown in this figure in front of you. Monteggia fracture. So Mishap thinks it's a Monteggia fracture. Alright. So perhaps guys, these are all very okay. So most votes are pouring in for Monteggia or reverse Monteggia. Alright. So I'll tell you actually, Sahil, you put D also by mistake somewhere. So reverse Monteggia. Well, reverse Monteggia is nothing else, I would say. You must have heard of a term called Glazy fracture. So Glazy fracture is same as reverse Monteggia fracture. Okay. So I'll just go one by one. choosing the correct answer here. Boxer's fracture is out because this is a fracture of neck of fifth metacarpal, and this is a fracture that's shown over here is involving this bone ulna. तो ये ulna का fracture है, तो boxer's fracture तो हो नहीं सकता because boxer's fracture would mean the fifth metacarpal involved. So out. So there is something else that is the answer. Now let me tell you what is Monteggia and what is Glazy in a very clear cut way. In Monteggia, there will be a fracture you will see involving the proximal ulna, plus there will be a dislocation that will be seen involving the proximal radio-ulnar joints. Like see, the proximal third of ulna broken, and I hope you can see this radial head going in the air because this proximal radio-ulnar joint is having a dislocation. Now somewhat a counterpart of this Monteggia is reverse Monteggia, that's also called as the Glazy. So Glazy fracture, I am calling it as reverse Monteggia. Now here you will have a fracture that will be involving the distal third of this bone radius, plus here you will find a dislocation that will be involving the distal radio-ulnar joints. Like see here, this is distal third radius broken, and see this ulna going here in the air because this distal radio-ulnar joint is having a dislocation. So ये distal radio-ulnar joint dislocate हो गया. So something common to both these injuries would be these dislocations involving the radio-ulnar joints. Now let me go back here. Look at this ulna. It's actually the distal third ulna, and then please see this radio-ulnar joint. No dislocation at all. There is no dislocation of the radio-ulnar joint that is here. Okay, and see this radio-ulnar joint also, no dislocation here also. So both joints are okay. So this is what becomes the answer. So if you simply have a fracture involving the shaft of the distal third of the ulna, that's what is called a nightstick fracture. So basically someone is trying to hit you with a stick and you put your forearm in between, the stick hits your distal ulna, it's only the distal ulna that fractures, nightstick fracture. So are you guys crystal clear with these injuries also? Are you guys clear as to what is a Glazy fracture, what is a Monteggia fracture, and are you guys clear with one important fact? A reverse Monteggia is Glazy, but Monteggia is not reverse Glazy, please. मतलब ऐसी कोई टर्म नहीं होती रिवर्स ग्लेजी जिसे तुम Monteggia बोलो, प्लीज. नो सच टर्म इज देयर. Monteggia is Monteggia, reverse Monteggia is Glazy, and nightstick is only ulnar fracture with no radio-ulnar joint issues. Clear? Yeah, it's a clever question. Well, a clever examiner just knows how to fool the students. All right, so when the examiner wants to trump you, he'll put such questions. But a clever student is one who's practiced such questions because he's watched and learned from the teacher nicely. Okay. So making you all clever students to tackle clever examiners. Fair enough. So that was a bit of discussion on upper limb fractures. So similarly, I'll take a bit of time because we're almost done with half of the session and maybe another 30-40 minutes left with me. So now I'll also like to discuss some lower limb injuries, but again I'm focusing on one special thing. You can see how well I'm showing you the x-rays, how well I'm making you read the x-rays. There's a very strong recommendation from me that develop the habit of seeing the x-rays and try identifying these fractures looking at the x-rays. वो ज़रूर करना. What I have observed with my experience over past few years, plenty of x-rays, and even if there was a theory question, where an x-ray had to be shown, nothing was written in the theory part. You had to read the x-ray and imagine what the examiner wants to ask you. So please keep looking at all these images nicely and develop the habit of finding bones on x-rays, identifying their anatomy and deciding about the injuries. Clear? So Mishab thinks this is Jones fracture. So Mishab, you know what is pseudo-Jones then? Or you know what is dancer's fracture? I'll clear it to you. So your guess is pretty much right. Jones. Yes. That's the correct pick here. This is Jones fracture. Now again, these are very close terms. So what you have in Jones fracture, I'll just brief you first. you have a fracture that will be involving the base of the fifth metatarsal. But again, this will be a fracture that will be involving the metaphysio-diaphyseal junction. So this will be the metaphyseal fragment here. This is the diaphyseal fragment here. So you can see the fracture line is basically bifurcating the metaphysis and diaphysis. So that is what is happening in Jones fracture. Now, contrary to this, a pseudo Jones fracture will be somewhere involving this particular area, the tip. So when you have a fracture that is involving the tip of the fifth metatarsal base, that's where you call it pseudo Jones fracture. And pseudo Jones fracture is synonymous with dancer's fracture. मतलब pseudo Jones fracture को ही dancer's fracture भी कहते हैं. Okay. Now in the NEET PG paper, once this question has been there, that which is that muscle that leads to these fractures here. Like you can see, there's a muscle that is coming and attaching to this fifth metatarsal base. So it's full of this muscle that creates these injuries. So can you name that muscle up for me? Yes, Bishop. So can you see there's a muscle attaching to the base of the fifth metatarsal. So pull of this muscle would generally generate these injuries. So can you help me out as to what is this muscle expected to be? So which is that muscle that is attached to the base of the fifth metatarsal that produces these injuries? Yes, please. So can you guys help me out a little here? Yes, Mishra, Sahil. Anyone, not just Sahil and Mishra, other people can also participate. Alright, no problem, I'll help you out with this. The muscle that is attached at this point is peroneus brevis. So these fractures are basically because of the pull of this muscle peroneus brevis. Clear with that? Apart from this, few more important injuries around this area. Now this is the third metatarsal, and this is all callous because this is a basically stress fracture. So if you have a stress fracture involving the distal shaft of either second or even the third metatarsal, in this particular scenario, the fracture is called March fracture. Clear with it? Some books have wrongly given March fracture to be a fracture of the neck. The answer is shaft. It is the distal shaft that fractures. So this is the shaft and this is distal shaft having the fracture. The neck would be somewhere around here, that is free. So I've shown you the picture in a very crystal clear way to clear this query so that you don't fall trap to wrong information in some books. So I hope you guys are thoroughly clear as to what is the March fracture. Now a similar kind of a stress fracture is visible here around the distal fibula. So what you see here is stress fracture that's involving the distal fibula. Now this particular question was there again in the FMGE exam, and it's only one book, Apple's book, where I've been able to find this term, runner's fracture, and Apple has clearly written this as a stress fracture involving the distal fibula. When this question came, there was a choice: proximal fibula, distal fibula. The question was, what is runner's fracture? So I hope you are clear with this exact terminology. This is a stress fracture that involves the distal fibula. So are you guys thoroughly clear with these terms? Okay. And one small more confusion regarding two fractures in the lower limb. See, a very important mode of injury where the lower limb bones can be involved tends to be this injury: fall from height. So two important fractures that can be there if you fall from height. One is jumper's fracture. Now jumper's fracture is basically a fracture that involves sacrum, like I've shown over here. This particular injury, U-shaped fracture, this is jumper's fracture, And this also happens in fall from height. And sometimes when you fall from height, you land on the heel, this bone calcaneum. So in lower fracture, it is the calcaneum that fractures as you fall from height. So this is how the lovers fracture would look like. So very simple. Fall from height, you land up with sacrum fracture, label it as jumper's fracture. Fall from height, you land up with calcaneum fracture, label it as lover's fracture. Clear? And yes, if you have any confusion, why separate names or almost a similar mode of injury, I'll tell you the very simple thing. See, normally someone who would fall from height would be a jumper. Okay. But yes, lovers also fall from height. Must be having some personal experience also, some people. Suicide, you try that up, fall from height. So actually, lover's fracture got named so because of the incidents that got associated with him. Actually, a lover was with his girlfriend and they were making love on the rooftop. And that lover had to jump. And that lover had to jump because the husband of the girlfriend came. So husband of the girlfriend came, so the lover had to jump. And now when the lover jumped, he landed on the heel, fracturing the calcaneum. And since that day, this calcaneum fracture got called as lover's fracture. Got my message, guys? So calcaneum fractures in fall from height, lover's fracture. Sacrum fractures in fall from height, jumper's fracture. Clear? So are you guys clear with these terminologies? और ये confusion दूर हो गई है and yes. Just in case कोई ये पूछ ले, overall the most common fracture you might come across in fall from height, that is actually the D12 vertebra, the 12th thoracic vertebra. So this is the commonest injury that you'll actually find in people who come to you with fall from height. But apart from it, the pelvis sacral area, the calcaneum, other injuries that are commonly possible in people who land up with this mode of injury, fall from height. So please do remember about some of these injuries that are commonly seen in people who land up with this fall from height. Now this bone here is the talus, and I hope you can see there's a displaced fracture involving the neck of talus, because talus is a bone where there will be a head, a neck, a body. So guys, this bone is the lower tibia, this bone is the talus, and beneath talus this bone is the calcaneum. So that is the anatomy at the foot. Talus would have a head, a neck, a body. तो talus में एक head होगा, एक neck होगी, एक body होगी. Now fractures in the neck of talus are particularly a common scenario, and this particular injury that's labeled in orthopedics as the aviator's fracture. Clear with that? No, ortho with life lessons. Yeah, absolutely right for that comment, Sahil. Alright. So aviator's fracture is clear. This particular fracture is particularly common because of like a very important complication associated with it. Going here on the top of the talus or the dorsum of the foot, I think you're very well aware, guys, is the dorsalis pedis artery. Now dorsalis pedis artery would give a branch that would travel through the head and the neck and go on to supply this body of talus. So if there will be a fracture involving neck of talus, the blood supply to the body will be gone. And I don't think I will even need to tell you what is going to happen to the body in this case. Yes, Sahil, AVN, avascular necrosis. So there was a question in the FMGE exam last year that which part of talus undergoes AVN in a fracture of the neck, and that was the answer, body of talus. Clear with that? So I think this pattern of blood supply is self-explanatory, तो ये देखते ही समझ में आ जाएगा. So this is a fracture involving neck, and see this body all become white because this bone has gone dead. A dead bone is pure white because there is no decalcification in dead bone because there is no vascularity. So you see this white bone, that means this area is undergoing avascular necrosis. So that will be the head, that will be the neck, and that will be the body. Okay, so please see the head, see the neck, and see the body. That body is all white because of avascular necrosis. So please have a good look at these x-rays simultaneously. Okay, now in this aviatus fracture, I would like to take you through one very important rank building MCQ. An MCQ where you might be asked about something called Hawkins sign. Hawkins sign is a special sign that predicts the risk of a fracture of neck of talus landing up with AVN. तो suppose किसी को neck talus का fracture हो गया, we want to make a prediction like as to whether AVN will happen or not. So you can use the Hawkins sign. Now you find a zone of lucency in the subchondral area. So I've just marked this up for you. I hope you can see a faint black line here. Now this top of talus will be called as dome. तो dome के बिल्कुल नीचे की black line दिख रही है. You see this black line, that means there is vascularity present and there will be no AV. So presence of Hawkins sign means no chances of this talus going into AV. All you have to see is that subchondral lucency, that blackish line visible under the talar dome, and this is almost at 1 month after the fracture. So if the fracture has happened at 1 month, you see that blackish line, rest assured this talus is not undergoing AV. Clear with this? So I hope you are clear with this one small extra rank building MCQ as to what is exactly the Hawkins sign also. समझ में आ गया. Now this particular injury that you see over here, this is called a pylon fracture. A pylon fracture is basically a comminuted fracture that involves the distal tibial articular surface. Okay, so that's the distal tibial articular surface involved. The comminuted word means shattered. So when you find multiple type of fragments, when there are multiple small chips of bone lying at the fracture site, that's where you use the word comminuted. So if you have a shattered type of a fracture involving the distal tibial articular surface, this is where you are going to use the word pylon fracture. Clear with that? Okay, perfect. Now another very important injury. If you see here, there is a spiral fracture in the tibia. See this zone. So I hope you can pick up the fracture here also. Now something very strange in this X-ray. If you look at the fibula, it's totally intact. So this is simply an isolated spiral fracture involving the lower tibia only. The fibula is absolutely intact. This particular injury, guys, it's called as toddler's fracture. So clear with that? So clear with what is a toddler's fracture? समझ में आ गया? So I suppose we are clear with all these terms now. बिल्कुल अच्छे से समझ में आ गई है. Clear with that? So clear with what's a toddler's fracture, clear with what's a pylon fracture, clear with what exactly is this aviatus fracture. Okay, so you're clear with all these lower limb fractures in a very nice and effective way. बिल्कुल अच्छे से समझ में आ गए हैं. Yes. So first of all, before I move ahead, any queries from the area covered till now? So please, because I'm just speaking and you might have some queries जो समझ ना आई हो. So please just feel free to ask, because the whole idea behind having a live session that you guys don't go home with any kind of queries. So that is the whole idea. So please just feel free to discuss with me if anything is not clear, if you want me to repeat on anything from the area that has already been covered, or maybe if things are still clear to you but there was a concept that was different when things were taught in your class and I'm teaching something different to you. So please feel free to ask me in case, guys, there's any query. Yes. Anything not clear to you guys? I hope things are pretty much, see, your comments are directly visible to me, but I can only see few people interacting and other people not speaking much. So please just feel free to ask me a query if something is not clear to you, want me to repeat anything, or there's a thought in your mind that's different from mine. Alright, so I suppose things are clear enough to you. But even if something is not clear, you can ask me, interrupt me anywhere. I absolutely do not mind stopping and answering your queries. Perhaps guys, you will again notice I'm showing you x-rays again and again, and it's not that I'm just simply giving you a definition. I'm making you see everything on the x-rays. Again, I'm pointing it out to you. You know what my experience has been with these exams, FMG papers. Since last say 3 or 4 years, the trend is changing a lot. Somewhere down the line, the examiner wants you to be practically good. He wants to assess your practical skills. So what I've observed that you've been asked plenty of questions where x-rays or images have been part of the question paper. Examiner wants you to decipher the images, reach the diagnosis, and then answer questions. And that's why you will find that every damn thing I'm showing you, I'm trying to interact with you, show you the image along with it, make you read the image. So all these x-rays that I'm showing you, make sure you're looking at these x-rays. It's not that simply you should know what is Hawkins sign. You have to see this black line, because on a bad day you will find only this x-ray and nothing else in the exam, and you'll have to decipher that this line means Hawkins sign. That's what I intend to tell you. A lot of images have been there in the FMG paper. I'm discussing all high yield areas from the fractures area zone, and if you ask my experience, somewhere around 6 to 10 questions have come up from the orthopedic side, mostly from the fractures area for the undergraduates for the FMG paper. And here almost 80% of the questions have actually been images. So that's the whole idea. I'm focusing so much on these images, and I'm hopeful that you guys will also develop this habit as you're preparing for the exam, because still there's time to go. You'll keep looking at all these images now also, and even when you'll be revising. Alright, so we'll just keep going with you having not many confusions. So we'll just keep going, and again I'll show you an image that I just borrowed from the FMG exam that happened 6 months back. Very simple question was there. This image was shown to you, and it was written that this patient has sustained some accident. After that, he sustained some kind of an injury and has landed up with the deformity that is shown in the image post injury. So Sahil has done his homework very nicely. Absolutely right, Sahil. So I'm really happy with your response here. The diagnosis here indefinitely is the posterior dislocation of the hip. See, I must first tell you about the types of dislocations and what do you see in hip dislocation. If you talk of a hip dislocation, the hip can either go anteriorly or there can be a posterior dislocation of the hip. Now, by and large, what you tend to see in 98% of the cases is a posterior dislocation of the hip. And perhaps the reason is very simple. The mode of injury that leads to a hip dislocation, we simply say it's a dashboard injury. You're sitting in the car and suddenly the brakes are put on and the dashboard would hit your knee and the hip would get a posterior force and dislocate posteriorly. So since mode of injury is usually the dashboard injury, posterior dislocation of the hip is by and large the rule. So Tushar, Sahil, you are absolutely right. That image was posterior dislocation of the hip. But I will take this opportunity to tell you the deformity that you see in both hip dislocations, anterior and posterior. Now you can very well imagine this hip's position. It's in flexion. This leg is in abduction and this foot is in external rotation. So what you are having is flexion, abduction, external rotation here. Now in this scenario you can very well see the femoral head. It has slipped anteriorly. So the deformity you will find in anterior dislocation will be this fiber, flexion, abduction, external rotation. But see here, at the hip there is flexion, but this leg has gone into adduction and this foot has gone into internal rotation. So what you see here is fader, FADIR, flexion, adduction, internal rotation. So when you see this farther deformity, that is where there is posterior dislocation of the hip, because this is where the hip is going to go posteriorly. So if I show this picture to you, what you have at the hip is flexion, at the knee is adduction, and foot internal rotation. So you are finding the farther deformity here, so I am calling it as posterior dislocation of the hip. So I think looking at the image, you will be very easily able to pick up the type of the hip dislocation now. Now this is a little tough one, and let me see like if you guys can now answer this one. A similar kind of a question, and or question maybe with little different image, because I did not get the exam, I only got a retrograde feedback, was there in the FMGE exam that has just gone by. There were terms like this Thomas test and some other terms like this. Some kind of an image was there. So I took advantage. I thought that I'll just show you this image, maybe manufacture question of my own, but I will utilize this image to discuss all these tests with you. Now there's a clinical test being done here in a patient who's come to you with a neglected old dislocation of the hip. You have to tell me the name of this test that is being performed. Okay, so there's a vote for telescopy, there's a vote for Thomas test. Okay, so there's a vote each for these things. Anyone else who wishes to contribute and break this dilemma, like is it Thomas test or is it telescopy? Is it Thomas test or is it telescopy? Anyone who wants to put in more of his feedback and try to take me to one side, because 50% votes chal rahi hain. Sahil says it's telescopy and someone else says no, it's the Thomas test. So anyone who wants to break this 50% wala voting and put his vote to one side and give me a solution as to like what is the answer here. Yes, please Tushar, you can put in if you want to. Mishab, you can put in. Smriti, you can put in. So anyone, people who are watching, please no negative marking in my class. So this clinical test that is being performed in front of you for an old neglected traumatic dislocation of the hip, someone landed up with the hip dislocation but did not go to the doctor. So what do you think is the clinical test that is being performed by this doctor? Can you just help me out? Anyone else who wants to put in the answer here? Alright, so no issues. You need to see if you don't know. I'll go one by one and rule out other options and come to the perfect option, and of course tell you about each of these tests around the hip. See, McMurray test I'll strike out first of all. सबसे पहले मैं इसे out कर दूँगा. It has no relevance here. This is entirely a separate test and is a test for meniscal injury in the knee. तो नी में meniscus में इंजरी होती है तो मैकमोरे टेस्ट की कोई रेलिवेंस बनती है. सो दैट्स आउट. सो व्हाट अबाउट बार्लोस टेस्ट? दिस इज अ टेस्ट फॉर congenital dislocation of hip. Congenital dislocation of hip. This is a test that is meant for first 3 months of life. And here it's an old patient, an adult that is visible to you. So that's how the Barlow's test is also out. And it's clearly written, a traumatic dislocation of the hip, not congenital. So that is why I am taking out the Barlow's test. Otherwise Barlow could also have been the answer here अगर वो word traumatic ना लिखा होता. But because congenital dislocation of the hip is tested by Barlow, and then of course it's done in small infants less than 3 months of age. So Sahil has given a very good answer here. He says the answer here is telescopy, because telescopy is what you would do for hip instability. Absolutely right. See, if there is an old dislocation, hip is unstable, hip is unstable. See, hip could be unstable in an old neglected traumatic dislocation, or hip could also be unstable in people who have a congenital dislocation. So basically all long old type of dislocations in the hip, the hip will be unstable because the hip will be in the soft tissues. So basically unstable hip means the femoral head is dislocated and in the soft tissues. That is what is meant by an unstable hip. Now in this particular scenario, the clinical test that will help you detect that instability is eliciting telescopy at the hip. The word telescopy basically means you are able to feel a kind of ballotment at the hip. Ballotment. To and fro movement. So guys, please understand. A telescope has that sliding movement. You can slide open a telescope, you can slide and compress it. So that sliding movement of the telescope is what I am calling as ballotment or telescopy. So you are holding the knee, leg, this thigh. The other hand is kept at the hip. So you give that push-pull movement. If the head is in the socket, there will be no push-pull movement. But if the head is out of the socket, there will be a push-pull movement, and this head will move here, and this hand over here can feel that sliding of the head, femoral head. So that is what is telescopy. And telescopy is a clinical test that you may find in both these scenarios, an old traumatic dislocation or even a congenital dislocation. But for this congenital dislocation of the hip, you have one extra test, Barlow test. Okay, and that Barlow test is only for congenital dislocation, and this is for infants. So I hope you're clear with all these tests till here. यहाँ तक ये तीनों टेस्ट समझ में आ गए हैं. Now I'm only and only left with Thomas test. So I'm only left to explain to you what is the Thomas test. बाकी सब explain मैं कर चुका हूँ. So I'll start explaining to you, of course, what is Thomas test also in a while. But before that, can anyone else give me the message, like as to what is the purpose behind Thomas test? कोई और बता सकता है मुझे? See, because this question was there in the exam that has just gone by, the FMGE exam that has just gone by in the end of July. This question on Thomas test was there. So I want you guys to be absolutely thorough with what is a Thomas test. So please, do you have an understanding of Thomas test? That's all what I want to know, so that I can decide the depth to which I need to penetrate that area, so that I can make the things clear to you. So Thomas test is for a flexor power check. Alright. So this is where even while you are faltering. Not the perfect answer. Flexor power check is not the perfect answer. The flexor of the hip is a muscle called iliopsoas. And Thomas test has nothing to do with checking the power of iliopsoas. I won't say that's the length of iliopsoas. Not even that. Well, I'll tell you the exact word I wanted to hear actually, that somehow no one is pointing out. For measuring a fixed flexion deformity involving the hip joint. So that's the exact scenario for which you would do a Thomas test, for measuring a fixed flexion deformity at the hip. Clear, guys? Okay, I know I need to give you some more insight into this Thomas test, because this is a little different, a difficult topic for you. I would do that. So let me just show you what is the Thomas test. Let me just explain to you what is fixed flexion deformity at the hip. Okay, and how it develops. Now, problems around the hip are very difficult to detect, and sometimes people have problems around the hip, but you can't localize that this is the hip joint that is involved, because the hip is not a percutaneous joint. It's not located directly under the skin. It's not so well palpable. Getting it? Now, sometimes people have some minor kind of a problem in the hip, tuberculosis in the hip, avascular necrosis in the hip. So they are having a chronic hip pain due to some hip pathology that has not been noticed by the doctor since a while, because he could not localize it. It's the hip joint that is getting involved. Now, because of this chronic pain in the hip, there has been a flexion contracture involving the flexor muscles and the joint capsule. So basically, this anterior capsule of the hip joint here is contracted because of that chronic pain in the hip, because of that underlying avian or TB, or maybe something like Perthes disease, well, any issue. So basically that pathology was present since a while, and because of the presence of that pathology, the flexor muscles, they underwent spasm, because muscles become spasmodic due to pain stimulus, and as the muscles went into spasm, these flexor side muscles, the front muscles, the joint capsule, they are contracted and develop a contraction. Now in this scenario, if the flexor side, the anterior capsule, the flexor muscles become tight, the upper part of the trunk will bend like this because of this contraction. Now please note, Sahil, with this kind of a posture, it is very difficult to walk. The entire mechanics of the body has been designed by God in such a way that you stay upright. So a compensation that will happen in this stage when the flexion contracture develops at the hip will be increase in the lumbar lordosis that will make the body go upright. So please, this curve you see in the lumbar spine is lordotic curve. Normally also lumbar spine is like bit lordotic. So normally the lumbar spine will be bit lordotic like this. So here that lumbar spine will become more lordotic like this, so that you can maintain like a correct upright position. So guys, sometimes you have these kind of pathologies in the hip and they are generating that chronic pain in the hip, and sometimes you don't immediately go and see the doctor because the pain is bearable. Because of that chronic stimulus, the flexor muscles have undergone spasm, but still you are able to walk upright because the lumbar spine has become lordotic. And since you are able to walk upright, you still don't see the doctor until unless the situation crosses that tide mark where the troubles become very serious. So many a times people with those hip problems, when they come to me, they are already in that compensated scenario, and now the problem is that he has some pain in the pelvic area. Now I have to decide that this is a hip having a problem. So this is what I do when I suspect that there is a flexion deformity at the hip. I subject this patient to what I call as the Thomas test. I make this patient lie on the couch, and now please let me say that this side where I have put a tick mark, this left side hip is having a problem. Now when this patient will be standing, he will be standing straight because there is lumbar lordosis is developed. So when I make him lie on the couch, I flex his normal hip like I have done over here. Completely flex the normal hip. Now when you flex the normal hip, this obliterates the lordosis. तो जब ये नॉर्मल हिप को फ्लेक्स करोगे, लॉर्डोसिस ऑब्लिटरेट हो जाएगी. There will be no space left between the back and the bed. The lordosis will be all gone. And once you obliterate this lordosis by pushing the normal hip on the affected side, the flexion deformity will now appear in front of you, and you can measure the angle with the bed and you will get to know the amount of the flexion deformity. So guys, let me go back. So now I hope you are clear the purpose of Thomas test, to find out flexion deformity at the hip and measure it. And that will give you the idea that this was a patient who is carrying some kind of a hip pathology, and an X-ray needs to be done because he was carrying some chronic pain in the hip since long he was neglecting. So I hope, although a bit tough explanation, but since this question has been there once in the NEET PG paper and it's recently been there in the FMGE paper, I felt that this needs an explanation in a very detailed manner. So are you guys now thoroughly clear as to what is the Thomas test, how it measures the fixed flexion deformity, when would you need to measure the fixed flexion deformity? And I hope you are clear what is the purpose behind telescopy also, that hip instability. I hope how these two tests are different, telescopy and Barlow test. And I hope you are clear McMurray is absolutely separate a test for meniscal injury at the knee. So are you guys comfortable now with all these clinical tests? You're clear with these tests around the hip, specifically Thomas, telescopy, Barlow. समझ में आ गया? So can you give me just thumbs up, guys, if you're clear with everything till here? यहाँ तक चीज़ें अच्छे से समझ में आ गई हैं तो प्लीज़ जस्ट गिव मी अ थम्स अप प्लीज. साहिल, you are thoroughly clear with these tests because you'd answered it somewhat nearby to the correct answer, but I hope you understood exactly the purpose being perfect enough. So Tushar, clear with that. Smriti, clear with that. Mishab, clear with that. So are you other people also, are you guys all clear with this explanation here? So I hope you are all clear. Okay, fair enough. Harikesh, you are also clear. Wonderful. Thanks for giving me the thumbs up. So I'm done with it. I've cleared this all part to you. But again, I'm putting up a big star on Thomas test. Okay. Some students who appeared in the exam gave me the idea that maybe a picture of this sort was there, and it was the Thomas test that was shown to you and you were asked about this test. So just in case that question gets repeated, you never know, that may happen. So for that particular scenario, I just want you guys to make sure that you don't repeat that mistake again. Already this question has been there in the NEET paper 2 years back, Thomas test, and it was in the FMG exam just on this July session. So please be prepared with tackling any question on hip clinical tests. Now another very, very nice question. A 28 years old marathon runner has come to you. Very, very common scenarios now. These sports problems, sports injuries, बहुत common हो गई, because the number of people who are getting involved with sports are on exponential rise, बढ़ते ही जा रहे हैं, because the amount of money and glamour that is associated with sports far outweighs what is even associated with the medical profession, where you are not even allowed to prescribe branded drugs. You have to just stick to generic drugs because no one wants the doctor to earn money, the thought in the market. So more people are going towards sports rather than medical profession. In fact, I very well remember my time when I was a small kid, and I would tell my mom that, Mom, I am sick and tired of studying, I want to go out and play. My mom would give me a tight slap. Idiot, you want to play? No, study, because when you grow, I want you to become a good doctor. That was the kind of teaching at my time, and I'm damn sure that by the time you guys grow up and you guys would have kids, और तुमने जाके ये घर पे बोल दिया, you go home and say कि no mom, I don't want to play, I want to study, your mother will give your child a slap कि यार पढ़ना चाहते हो, खेलना नहीं चाहते, पढ़ना चाहते हो, मैंने पढ़ के क्या कर लिया, what did I attain by studying? Go and play, more money, more fame, getting it. So spectrum has changed. Lot many people are getting involved with sports now, so their injuries are increasing, their problems are increasing, and that's what expected from a doctor, that you should be able to handle all these sports injuries in a very effective way. So a marathon runner who's come to you, he ran a race and he developed some anteromedial pain on the tibia. Initially it was mild, but as he's running, that pain has become progressive and it's increasing in intensity. Now, usually an X-ray would be done first up. That has been done and it's come out to be totally normal. So you have to tell me the next course of action. Now this is exactly the next pattern question जो कुछ FMG पेपर में भी आने लग गए हैं, where there are multiple steps involved in reaching the answer. So before I tell you the next course, the first step that has to be sorted here is what is the diagnosis. And then once you know what is the likely diagnosis here, you will be able to decide upon the next step. So anyone who can first tell me as to what is the likely diagnosis here? This athlete having that shin pain on the anterior medial tibia, and that's increasingly progressively increasing as as he's running and practicing more. So what is the diagnosis here first, guys? So please help me out with the diagnosis, and of course I will help you out as to what would be the next course of action for this case. तो पहले मुझे ये help out करोगे, like what is this condition looking like? Yes, Harikesh, Sahil, Mishab, तुषार, स्मृति, anyone, like क्या चीज़ लग रही है इसमें, प्रॉब्लम क्या लग रही है? So first tell me the problem, and then of course I'll help you guys out like as to what would be the next course of the action. Okay, so maybe Sahil has pointed out that maybe bone scan is the best, but Sahil, do you have an idea as to like what is the diagnosis here? Like, is it infection? Because if it's infection, you might have to go with bone biopsy, or maybe an ultrasound if there's an abscess formation here. And that's scanogram. It's basically a full length X-ray only of the lower limb. So if you take a full length X-ray of the lower limbs, that's what's called a scanogram. So scanogram is basically an X-ray. So should an X-ray of the full length be done, because it's likely not the leg, it's some referred frame from some other side. Alright, so no one knows the diagnosis. No problem, I'll tell you. The diagnosis here, I'll just, sorry for that bad handwriting. Shin splints. So please accustom yourself to this term. There was a question on shin splints in the AIMS paper 2 years back, and you never know when this can jump onto to your paper. So Sahil, please, this is not runner's fracture. So maybe you're correct with the answer here, but by luck, this is not runner's fracture. This is actually a case of shin splints. A runner's fracture will be involving fibula, and you can see the tenderness here is on the tibia. So clear with the mistake, Sahil? Shin splints. So I'll take this opportunity to provide some information on as to what are these shin splints to you then, guys. Shin splints is more or less the athlete's term or the layman term. A doctor better calls this condition as medial tibial stress syndrome. So just in case you guys have not been taught in the routine classes, here's some information I'm sharing for you guys here. Okay, on medial tibial stress syndrome. So this is basically exertion related pain in the shins, usually located at the posterior medial aspect of the distal leg, but can be on the anterior medial aspect also. So tibia shin, exertion related pain, progressively increasing with exertion. One thing. Many a times it's bilateral also. Okay. And usually on the posterior medial aspect, but can be on the anterior medial aspect also, depending on the scenario. Now the basic problem here, please understand, it's basically again a repetitive stress injury because of the contraction of these muscles, tibialis posterior, soleus muscles, as you run, because you are an athlete. So those repetitive muscle contractions, because muscles are basically originating from bones. So as you are running too much, not warming up properly, those repetitive muscle contractions have led to a stress injury on the tibia. Is it tibialis anterior or posterior would decide the site of the pain. Usually it is the tibialis posterior that is mostly involved. Now, in case you allow this condition to progress and don't stop the activity, then a frank stress fracture may become evident eventually. So that is the whole idea of identifying this condition early, giving a break in the activity, and finally prevent this catastrophic stress fracture that might just spoil the career of the athlete. Now, until unless this fracture develops, the X-rays would usually be negative. But even this early stage, a technician bone scan or an MRI may be particularly helpful to reach the diagnosis. Now, you have to decide whether it is just the stress injury or even some periosteitis, that periosteal inflammation or frank stress fracture. That difference can also be attained from these. Especially MRI will be very precise to tell you, is it just that periosteitis that is right now happening, or is it that frank fracture that has developed. So MRI, I would say, is the investigation of choice here, even more than bone scan. But bone scan, I'll call it the second best. So earliest diagnosis, best diagnosis will be attained by MRI, and bone scan is just next in the line. So lucky Sahil, lucky. But please, luck favors those who are trained. Luck favors the trained mind, for serendipity, that famous quote. So somewhere down the line, you had some knowledge and you were able to rule out the other options. So luck favored you. That's what I would say. Okay. So treatment is that activity modification. Give rest, restrict, stretch the involved muscles. Okay. Give NSAIDs. So it's all symptomatic treatment. Basically, you have to be preventing that stress fracture. So that's medial tibial stress inflammation splints from my side to you. So here I would say bone scan, that will be the best answer. So are you guys clear with this? So there's no infection here, no abscess here, so that's why no rule of no tumor here. So biopsy, ultrasound, that's all gone. Okay, so bone scan would be the best scenario here. So are you guys clear with this also? समझ में आ गया? So that's all from my side, guys, for today. Any queries before I can close the session? Anything not clear to you? कोई चीज़ समझ में ना आई हो? Clear with all this? Anything you want me to discuss before this session is over? Right. So you wish to attend more classes from my side? Of course, you'll have to subscribe then, because this is just a promo session, and more information and more concepts will be shared in the plus classes. You can subscribe to Unacademy Plus notes and the mentoring sessions from the top educators we have with us by taking the iconic subscription. Huge discounts are right now being offered if you check up the website. And just in case you have an exam that's still to be taken in a little while and you have time with you and you want to clear your basics and master them up first, then I'll just bring it to your notice that we have now the NEET PG Vitals also available with us. So here you have all the recorded videos from all educators, recorded in very comprehensive way, where every concept and every information has been discussed very precisely, so that right from the basics you grow so strong. So you can subscribe and get all these advantages. And the live session you have just experienced, how well you can go home without a query, all things can be sorted in the live session there and then. In case you are subscribing, you can use my code also, OrthoLive, to fetch your discount. Okay, and you check up the website, you will have all the details about all these things. So that's all from my side for today. So before I close the session, anything you want me to repeat again, anything that you think was not clear to you, anywhere you want that I should be more elaborative, please let me know. Yes? Alright. So in case you are comfortable with it, so people who are going to pay for the FMGE exam, I'll just take 2-3 more minutes and give you some very important guidance from my side. FMGE exam is a very basic exam, but examiner, as far as orthopedics is concerned, I have been noticing is specifically interested in checking your practical skills. So questions will be simple and more so practical nature. They would love to see whether you attended your clinics or not. So you would be asked a lot about clinical images, x-rays, clinical signs, clinical tests. Traumatology, although not that important area, maybe from the NEET PG perspective, is particularly important for the FMGE exam, and perhaps because in many countries traumatology is just a separate subject. So a lot of questions come from the fractures area. That's why I've tried discussing and wrapping up the fractures in this area. Now, what to study for the exam? the recommendation from my side. Go through the NEET PG recorded videos, NEET PG Vitals, and download the PDFs and read all the notes. Okay, so this has to be done along with the notes. Once this is done, the Unacademy question bank is carrying all the repeat questions and some extra questions to help you practice. In case you are able to do this much from this Unacademy platform, you can rest assured you will be through. For INICT and NEET PG, well, Sahil, knowledge is same everywhere. The same basics and same everything will be utilized even when you're going with the INICT and the NEET PG paper. But yes, you'll have to prepare a little extra. You'll have to make sure you miss on no classes. You'll have to attend those top-up sessions that are taken by the educators. Okay, and you can try practicing some question bank from your side, and any queries you have, you can refer them to me, ask me, and clear them up. Okay, so anything else you want to ask me before I can just close the session? Yes, any other query, guys? Please, any other query you want to ask me before I can close the session? So I hope you're clear about what to study. Okay, make sure you go through the repeat questions and watch these lectures on Unacademy and subscribe. And for subscribing, make sure to use my code if you want to fetch your discounts. Okay, so good discounts going on the platform, so check out the website. We'll be looking to having some of you as subscribers on Unacademy. So hope you enjoyed this session. All the best to you guys from my side for the upcoming exam. Good night, stay in touch, and subscribe. Bye bye.